Okay. Sound is okay? Everything is going okay. All right. Okay. Good morning. Good morning. Okay, sporadic. Good morning. Good. What's wrong with this side of the class, by the way? Oh, okay. So everybody moved, okay, to this side. All right. What we'll do is we'll finish off the hypersensitivity and type 4 hypersensitivity that we were in the middle of, and then move on to the next topic. We compared different types. Yeah, it is on. Yeah. All right. So the hypersensitivity, there are three different, appearances of it. One is contact dermatitis, and I gave you the example. Poison ivy is the best example. Macropapular sort of lesions. The one looks at the histology. There will be T cells and macrophages there. The tubercle reactions, the same time course, roughly same time course, but it is characterized by induration, hard thickening. And the one looks at the histology, one would find monocytes and lymphocytes. And examples are lepramin, leishmanian, tuberculin, those tests, diagnostic tests. Then there is granuloma, which is a sort of long-term exposure to the antigen, persistent antigen and persistent type 4 reactions. And that is characterized by hardening, if it is superficial, but often it is, in the cavities. It's just like tuberculous lesion in Mycobacterium, tuberculosis and lung lesions, okay? Or leprosy that are skin and muscle lesions. And that's characterized by macrophages and fused macrophages that form giant cells and a lot of epithelioid and fibroblast cells, okay? And as a matter of fact, that thickening, hardening, is due to the proliferation of fibroblasts. So what you see in the tuberculin reaction is because of the fibroblasts proliferating and thickening that particular area of lesion. By the way, the tuberculin reaction is sometimes referred to as MONTOX, M-O-N-T-O-U-X. So if you see MONTOX reaction, equate it with tuberculin reaction. Okay, so that's the different kinds. The mechanism, if one goes, of course, there's a basic internalization. And these reactions are often, at least if it is infection, often with intracellular organisms. That doesn't mean to say that extracellular organisms or extracellular proteins cannot give cell-mediated or delayed hypersensitivity. Okay, antigen is processed, presented on the cell surface together with class 1 MHC, Th1 cells in this case. In the other cases, they were Th2 cells, if you remember. And here it is Th1 cells are going to interact with the antigen, IL-2, interferon gamma, or TNF-alpha, they're going to produce, and lead to activation of macrophages that are going to, I guess I should change the light. Doesn't it work? Okay. Projection. Okay. It's a little bit more visible. IL-2, the activated macrophages are going to produce reactive substances as well as different cytokines, NO2, nitric oxide, interferon alpha beta, they're going to produce TNF alpha, they're going to produce an IL-2. And these all together, these cytokines are going to cause a proliferation of and damage and proliferation of fibroblasts and damage to the cells, okay, locally. And that's what would lead to actual reaction. NK cells, again, can get activated by these cytokines. They have got granules, and you already know what they do. They inject those granules into the target. They are going to obviously interact with the cells that have got low class 1 MHC. If you remember the Dr. McCallop's presentation on that. Then, of course, if they are fibroblasts that have got also class 1 antigens, and they are going to recruit pre-T cells, pre-TC, and they are going to get activated. And once they are activated, they have got more of these granules, and these granules, porphyrin and granzymes, are going to cause damage to the local area. This part of the interaction, of course, will occur only if the antigen is processed from within. Antigen is from within the cell and is processed and presented together with class 1 MHC. Now, it is not a totally cardinal rule that the cytotoxic T cells can be generated only from the antigen that comes from within. There are some mechanisms. In exceptional cases, the external proteins that are internalized by APC can also sort of be cross-presented together with class 1 MHC. But that's more exception than a rule. As a rule, intracellularly produced proteins will be presented together with class 1 MHC, okay, and the ones that are taken in by endocytosis or phagocytosis together with class 2 MHC. But there are some exceptions. All right. To summarize the different kinds of type 4 hypersensitivity, if there's a continuous presence of antigenic stimulation, it can lead to both either contact dermatitis or granuloma. Okay? If it is a soluble intradermal injection, just like in the case of tuberculin reaction, okay, or exposure to things like poison ivy, poison oak, etc., it will lead to contact dermatitis or tuberculin type response. Okay? So contact dermatitis can be both chronic exposure as well as the intradermal or dermal exposure. Okay? Those are different manifestations. We have already gone through that. Okay, so that's the type 4 hypersensitivity. If one compares different types of hypersensitivity, you've got a table that summarizes and compares different types of hypersensitivity. Type 1, okay, IgE mediated. Type 2, G or M, cytotoxic. Type 3, immune complex, mostly IgG, sometimes IgM as well. And type 4, no role for antibody. That's a very, very important, crucial message to take home message. Type 4, remember, the name itself tells you that it is cell-mediated. Okay? Type 4 is no role for antibodies. Antigen is most of the time exogenous. I do not know of any type 1 hypersensitivity where the antigen is endogenous. Okay? In this case of type 4, usually endogenous antigens, but it can be exogenous, and it is antigen is distributed on cells and tissues. Even when it is exogenous antigen, as in the case of, if you remember, drug-induced hemolytic anemia, drug-induced immune hemolytic anemia, the antigen, although it was exogenous, but it got coated onto the red cells, granulocytes, or platelets, depending on what sort of protein it could interact with and coat those cells. Type 3 antigen is soluble antigens. that forms immune complexes and can be deposited anywhere in any tissue. And the example, of course, was lupus in that case. Okay. Response time can very early. That's why it's also referred to as immediate hypersensitivity. No real temporal characterization of these two. Okay. In the case of type 4, very much delayed. That's why it was referred to as delayed hypersensitivity. Okay. Appearance, wheal and flare. Wheal and flare. Soft thickening, irregular soft thickening, like hives. Most of you have seen that in one place or the other. And then together with some erythematous appearance. Lysis and necrosis is type 2. Erythema and edema, you saw all those, the mechanisms as well as the examples of that. Erythema and edema is type 3. Erythema and induration instead of edema. Induration in the case of type 4. Okay. Histology, if one looks at histology of type 1 reaction, one would find basophils and eosinophils. You remember ECF8, eosinophil chemotactic factor of anaphylaxis, attracting eosinophils and basophils. Some neutrophils may also come in later on, but by and large it's eosinophils and basophils. In the case of type 2, antibody and complement are involved, but then they will attract some neutrophils because they are activation of complement by the alternative pathway. In the case of type 3, again, immune complexes are formed, and they attract neutrophils because of activation of complement there. In type 4, quite different picture. There are mononuclear leukocytes, lymphocytes, and monocytes or macrophages. If one were to transfer from one individual to another, not that we will do it in the humans, but if one were to transfer, the type 1 hypersensitivity can be transferred by antibody. As a matter of fact, in the old days, there used to be a test that has been abandoned, which depended on transferring antibody or serum from the allergic patients to a normal volunteer and then testing the normal volunteers for the reactivity in the local area where antibody was transferred. But that test is not done anymore. So type 1 can be transferred with antibody, type 2 can be transferred with antibody, type 3 can be transferred with antibody. Okay? But not type 4. For the type 4 hypersensitivity, you require T-cell transfer. Examples I've already given you as we went along. Hay fever, asthma is the most common example of type 1. Pemphigus, good posture, I showed you pictures of, that they are examples of type 2. Farmer's lung or SLE, systemic lupus erythematosus, SLE particularly, is a very well-known example of type 3 hypersensitivity. And TB test, Monter test, tuberculin test, lepromin test for leprosy, or leishmanian for leishmaniasis, those are examples of type 4. And also the more common examples are poison ivy, poison oak reaction, or granulomas. Okay? So that's the summary of all the types of hypersensitivity and what is, similarities or contrast between them. Okay? Any questions while I change the topic?